Actually, I'm going to present a case that is not done at my institution. This is a different institution that it does have as many.
So it means that you can express many criticisms because operator is not
Right,
there.
right. Because you're going to ask why I didn't have in the other case what you're going to see in this case. So let's start with this case. It's a 50-year-old male with only past medical history of hypertension. He is attended in medical attention for 1 hour and 50 minutes of symptoms, and is referred to the institution for primary PCI. This is the electrocardiogram, and this is the angiogram. The diagnostic angiogram was first to go for the lesion that was on the electrocardiogram, not a culprit lesion. But as you can see, here in the right coronary artery, you can see a total occlusion that it has also a big lesion in the vertical segment. So they proceed to do the angiogram on the left, and you can see the occlusion of the proximal LAD, which they start with the wiring, and then they try to pass the thrombus aspiration catheter that didn't went through. So they have to do the pre-dilatation with a small balloon, and then after that they did the aspiration with the expert. And as you can see, that's the result for the thrombus aspiration. As you can see, a large thrombus was shown that you can see in there. So they start making the control angiograms with pre-dilatation again, and then start having some non-reflow, and start using adenosine for try to treat the non-reflow phenomenon. After that, they start with stenting on the left main, and this is the final angiogram for the LAD. The patients remain asymptomatic with normal echocardiography, and 3 days later, they proceeded to do the CTO procedure. After they, as you can see, we usually, well, I say we because sometimes I work with Marcos, and we always do dual injection. We go with the algorithm, the hybrid algorithm to work. We go first to antegrade approach, and then the escalation of the guide wire. If we cannot get through, we go to retrograde. And in this case, we have to do they did the septal surfering. That is actually, as you can say by the name, you just literally you just push the wire to the septal and it goes through. It sounds very easy. Sometimes when you get a very good septal, it's really easy to get through the retrograde approach. So they changed for the pilot 200 guide wire cross to the retrograde cap, and they start doing the simple through lumen to through lumen retrograde wiring with the pilot 200, and after that they start doing the pre-dilatation and the stenting of the right coronary artery. This is the final angiograms with a very good result. And here is the things that for all of us can question, that the patient went to the CTO in this setting of acute STEMI, have higher mortality rate compared with the patient with multivessel disease, but without CTOs. Complete revascularization can be achieved on a regular basis with current technology and strategies. Decision to refer a patient for CTO intervention of a non-culprit STEMI vessel remains contradictory and should be individualized depending on symptoms, territorial risk, and the institution experience. Thank you.
Maybe we can maintain this slide, okay.
I think we have two different things to comment on this very interesting case. The first one is when we are dealing with multi-vessel disease and acute MI, when to treat, and I'll come back to that to ask a question to the audience. And the second part is the very elegant way to treat and solve the chronic occlusion. But my first question would be, forget about it is a CTO, a chronic total occlusion. Your strategy to treat multi-vessel disease on the acute MI setting, who would treat immediately other lesions? Before I would do three questions. Who would treat immediately? Who will defer and during the same hospitalization do the other vessels? Who would discharge the patient and send him home and then bring it back to do the rest of the arteries in another hospitalization? So my first question would be, who would treat immediately, forget the CTO, who would treat immediately the other lesions?
In the same setting.
Who would...
It just depends on the lesions. I mean, not every lesion is simple, and it depends on the time of how much dye you've used in that procedure. So you have to individualize.
Okay, so that's a good point. And then who would, bring the patient back to 1 or 2 days later to do the rest of the arteries? Who would discharge the patient and bring it back later on another hospitalization? So it is divided. With further testing. With further testing. Okay. How about CTOs? Because in this case, a CTO, bring it back to the cath lab 2 days later. It's something that we can. So, any comments? Would anyone like to take the microphone?
CTO won't wait for that because that's.
Please express.
First of all, you need to know why are you doing CTO? To prolong life or to relieve symptoms? We don't know if these patients are going to have symptoms after the LAD is open. And if you know that by syntax 4, right coronary is, when dominant is giving 16% of the, nourish the 16% of left ventricle, and you have already collaterals, I doubt that it will prolong life of this patient. So further testing to prove the amount of ischemia in this patient and the symptoms is necessary. No straight dilatation. And the second thing, third day is the worst day to repeat the contrast exposure regarding the kidney susceptibility.
Right. Remember, this is not Gustavo's case, and he's presenting someone else's case. And no. You are all right. I agree with you because we are not here to interrogate the presenter. We're here to share experience and to share knowledge. So I think your comment is excellent.
For sure, I agree with that CTOs must be not performing the 2 days later after STEMI. But in order to answer that thing, or in order to add a comment, CTOs don't prolong life, don't have any impact on mortality. Any CTO has impacts in symptoms, and the CTO open that argues that angina and is not improved in CTOs is the only one trial that doesn't show that. But the other trials goes in that way. CTOs relieve symptoms, relieve angina, improves the functional class of the patient, but do not have an impact on mortality. Not any CTO, but in this setting, having a CTO and going onto in a STEMI of a non-related CTO artery, those patients has a better outcomes if you have opened previously the CTO than if you doesn't. Maybe. So in this kind of settings, the patient would be different.
Comment what I often say, because you express a thing and then you have to challenge what he said.
Well, I don't see the challenge.
You probably agree?
I rarely do CT on the right coronary artery, honestly. If LAD is in question, then it has a sense. Secondly, this is clearly not a patient to discuss this anatomy in this situation, to discuss if he is going to get better or not. I certainly wouldn't do CTO in the staying in the same setting? No, because the artery is already open, the blood, everything is giving enough blood, and the collaterals are good. So,
For sure.
perhaps I didn't understand what was the challenge.
No, I agree with you that that
It's not
wasn't
the
the
CTO that doesn't improve life, you know.
no, the CTO doesn't improve life.
Yeah, it depends how do you set the study. If you have a large ischemic burden during the exercise test on the proximal LAD, and this is a CTO, you need to do something with that CTO. Either you put it cabbage, either you place the stent. And then, depending on the amount of the myocardium, that certainly has a effect on the life expectancy.
But what also has been published
This is not the
is
situation, but proximal LAD would be a situation.
Somebody will add some comment before the answer? No? Okay. You
what was
express.
being published is that the amount of ischemia, if it's more than 10% of the total myocardium, you must go through the CTO or to open the CTO. But also, in the other hand, it was published that you must have ischemia not only in the CTO artery territory, but also in the donate artery territory, because it's more amount of myocardium that you have to irrigate with one vessel. So the ischemia is not the only way. If you demonstrate a lot of ischemia, it's not only the patients that must be open the CTO, because you're not analyzing the donate vessels territory, and that patient must be benefit if you open the CTO in the other area.
Ischemia with the stress echo, not with the FFR. That has to be
Yeah, no, FFR in the CTO is not that good option.
So we go to the next one.
Yeah.
Still have time.
We have to maintain
Yeah.
the peace and not start the war. Okay? Of course, the patient is, the result is good, the patient is fine, and we mean that you have done a good job. But of course, each time you have to balance what could be the potential benefit for my patient. Is a discussion you have in terms of quality of life and in terms of longevity. Okay, what could be in this patient the potential benefit? What could be harmful is what you underline, or somebody underline 2 days or 3 days later about the kidney, and then cross with a wire. Maybe it can be harmful, and then it's a self-critical decision making about what could be the potential benefit for the patient.
Right, maybe the timing wasn't the right time to do it, but I guess that the reasoning for us to open in the CTO, that we work with that, is that the quality of life that we give to the patient is very different. We always talk about mortality, and we really don't know how much going to live the patient for our case. I mean, for the coronary, for the heart, for whatever cause. But the quality of life, if we can improve them, I guess most of the things that we do is just to improve the quality of life for the patients.
Okay.
Depends if the symptoms
Right.
are related with
To the
occlusion of the
occlusion.
vessel. Because of course, if the symptoms are not related with the occlusion of the vessel, you will not improve the quality of life.
Right.
So I fully agree with this
Right.
friend from Serbia,
too.
that by evaluating by non-ischemic, non-invasive tests, the potential ischemia induced or the potential viability of the territory is very important.
Okay, just
Thank you.
another point, Gustavo, before. You also did thrombus aspiration in this case, and you
Yes.
didn't in the previous one. So
Yeah.
what's your point of view on thrombus aspiration, considering how the guidelines have changed
Yeah, well,
on thrombus aspiration?
We usually do thrombus aspiration, but even with the guys said that there's no better in mortality and quality of life and whatever. But we perform but we changed the way that because I guess the way that you do the thrombus aspiration, that's the way they change the mortality. And when you see a lot of thrombus burden, I don't think that anybody just get happy just to put a balloon and then you still seeing or washing the thrombus and do anything. So we perform the thrombus aspiration. I can't say routinely, but we do it very frequently.
Again, one comment. Sometime before, when we was a student, we learned that when we have a patient with a myocardial infarction, before the discharge, you make a treadmill test. So at this point, almost nobody do this. What do you think, a treadmill test before discharge? If you were made the treadmill test and you demonstrate the ischemia, the panoramic is very different. But you didn't. So it's very important to retake the indication of the treadmill test before discharge after myocardial infarction.
Probably not only treadmill test, but other ways of looking for ischemia would be useful. But I mean, okay, okay. So we're gonna thank you very much, Gustavo,
Thank
again, and we're gonna move on to the next presentation.